Good afternoon. My name is Dr. Brian Matlaga, and I serve as the Executive Vice Chair for the Brady Urological Institute, as well as the Director of the Gerald and Helen Stevens Center for Stone Disease here at Johns Hopkins. And it's really my great pleasure to welcome you to today's session of Urology Speaks, which is titled Living with Genitourinary Cancer and Navigating Recovery. In the Brady's 100-plus year history, we have made significant advances in the diagnosis and treatment of patients with genitourinary cancers. These cancers, prostate being probably the most commonly known, but also kidney, bladder, and testicular cancer, are some of the most common among men and women. Fortunately, in many cases and for many patients, we're able to successfully treat this cancer, and our patients are able to live long, happy, and healthy lives. But, and that's what brings us here today, we see that our physicians and medical teams are caring for a growing number of cancer survivors, patients who are seeking guidance about how best to address some of the most common conditions that frequently arise after cancer treatment. The Brady is home to some of the most talented cancer surgeons in the world, but we know that the successful treatment of cancer does not necessarily end with removal of the cancer. Side effects of genitourinary cancers and their treatments are incredibly common and can greatly impact a patient's quality of life. Today's session will focus on common concerns we hear from our patients and the expert advice from 3 specialists at the Brady. We really hope that this session will provide useful information to both those who are living with genitourinary cancer and those who are navigating recovery, and to help all live full and healthy lives. We will end our time with a question and answer session with our experts, so please submit your questions anytime via the Q&A button, which is at the bottom of your Zoom screen, and we'll address as many as we can in the time we have allotted. So let's jump right in, and I'm really very delighted and excited to introduce our panelists, Dr. Farling, Dr. Singla, and Dr. Wright, and then we'll jump into the topic. So firstly, Dr. Kristen Farling is a nurse practitioner and has a doctorate of nursing in prostate cancer survivorship. In addition to running our prostate cancer survivorship program, Dr. Farling also sees patients with hematuria, urinary incontinence, and benign prostatic hyperplasia, otherwise known as B.P.H. Our second panelist, Dr. Nirmish Singla, serves as Director of Translational Research in Genitourinary Oncology here at the Brady. He also directs the Kidney and Testicular Cancer Program and co-directs the Upper Tract Urothelial Cancer Program. Dr. Singla's clinical practice spans the complete spectrum of genitourinary oncology. It includes cancers of the adrenal, the kidney, the upper urinary tract, the bladder, the prostate, penile, urethral, and testicular cancers. And finally, I'd like to introduce Dr. Jamie Wright, who is the Director of Reconstructive Urology and Neurological Urology at the Brady, and serves as Chief of Urology on the Johns Hopkins Bayview Medical Center campus. His clinical and research interests are in male and female urinary incontinence, complex voiding issues, and pelvic genitourinary reconstructive surgery. Dr. Wright is a sought-after expert in complex surgical repair of urologic function after trauma or complications from urologic conditions or disease. So thank you all for joining us. At the Brady, we treat a wide range of genitourinary cancers, but the most common that we see and treat is prostate cancer. 1 in 8 men will be diagnosed with prostate cancer during his lifetime. Our patients benefit from the Brady's decades of experience in the field and the partnership we've built with practitioners who focus on cancer survivorship. So one of these partners I'd like to initially reach out to get the conversation started is Dr. Kristen Farling, who leads our survivorship program for individuals and families navigating recovery from prostate cancer. Kristen is a wonderful resource for prostate cancer survivors. And can you start by giving us a better understanding of your practice and the types of patients you see?
Of course. I see a variety of patients. I see patients with hematuria, blood in the urine, overactive bladder, elevated PSA, enlarged prostate, a myriad of patient diagnoses. Probably what I'm most sought after for is the non-surgical treatment options for erectile dysfunction for various patients, and also looking at the survivorship needs of prostate and bladder cancer patients. It's very important for all of us to remember that this is a lifelong process for many of our patients. We do a fantastic job of curing patients of their cancer, but they have a long life ahead of them. And some of that requires managing the potential side effects or treatment effects that can happen with those cancer treatments. So it's important for everyone to remember that when it comes to survivorship, especially here at Hopkins and the Brady, we really strive to be with the patient throughout that journey and not just during the surgical and post-op process.
And one of the, I guess, first touch points that patients have following prostate cancer surgery is that 3-month follow-up visit.
Mm-hmm.
What is that appointment like, and what should patients expect during that visit?
The 3-month survivorship patient appointment is for prostate cancer patients. Not every patient comes to these appointments. It can be done for, patients can make an appointment. They can make an appointment themselves, or they're referred by their urologist. And we go over all different topics. And a lot of it is just validating patients. Sometimes they just want to have that safe place to be able to express their concerns and how they're doing from their post-op period. One of the things that we're going to look into is looking at that PSA. The PSA is a blood test that we do to monitor the prostate cancer. The goal was for it to be undetectable. So it's a fantastic tool that we have to ensure patients no longer have prostate cancer. But it also gives us an early opportunity, goodness forbid, if the prostate cancer were to return, or if we had a biochemical recurrence, we're able to identify that at such an early time to help patients in that process. So the PSA blood test is one of the things that we always talk about. We also review their activity level, their energy level. How are they doing? Are they back to work? Are they exercising? What are they doing to keep themselves active? We'll also delve into some more intimate and some more personal problems, reviewing their urinary control. Some patients are dry right from the stop, right from the start. Once that catheter comes out, they're dry. Other patients take some time. So they may have to have a little bit more of a coaching process, or kind of figuring out, okay, how are they doing? And sometimes it's a nice realization for the patient to say, hey, listen, I was going through 3 pads after that catheter came out, and now I'm down to 1. And they really see, hey, I am doing a great job in recovery. Or maybe they need some more coaching with the Kegel exercises or the pelvic floor muscle exercises. Maybe we need to refer them to physical therapy for pelvic floor training. So all that is involved in that 3-month appointment. In addition, we talk about sexual recovery. Sexual recovery is important for many patients. Now, some it's not. It's very individualistic as to, what their goals are from a survivorship perspective. Some patients really want to be proactive, and we talk about ways to do that. How are they doing with either pills that they're using for their erections? How often are they trying to get erections? Are they using vacuum devices? Are we doing any kind of traction devices for the penis? Are we doing any kind of injection therapy? So all these different options that we're able to explain to the patients and provide to them really gives them a framework of what to anticipate in the future. So it's a fantastic appointment for patients to be heard, to be listened to have their feelings validated, and hopefully reassured that they're doing a really, really good job in that recovery process.
And you touched on the last point you raised was on sexual function. What should men expect, both short term in the near postoperative period, but also longer term, looking out months to years from a prostatectomy? What do you counsel patients with regards to that?
When it comes to sexual recovery after prostate cancer surgery, it can be a lengthy process. So to have that expectation up front is very important. And we actually provide a webinar once a month for all prospective prostatectomy patients, where they come on. We do an hour evening webinar of what to expect during their hospitalization, after the hospitalization, urinary control, and sexual control as well. So many patients who take advantage of that educational opportunity already have some of this information up front, which is really, really important. But I do encourage them to have grace, to be kind to themselves, to recover from their surgery first. That's the most important thing. And to know it can take up to 2 years before we know what that new normal is. And that new normal can depend on many things. How were their erections before surgery? What are their comorbidities? Are they hypertensive, diabetic? Are they smoker? Are they obese? Are they on medications that may affect their erections? Was it partial nerve sparing or not nerve sparing? All of these things can have an effect on a patient's erectile function. So having that expectation, or that not having so much pressure on themselves to say, I need to perform right away. No, you can heal and you can go ahead and take your time if we need to. Now, there are some men that are potent right from the start. They have no problems having erections. Others need to recover, and they need to see, how that body responds. And that's how we go through all these different options for them in terms of either vacuum therapy, which is a great option for both passive and active recovery. There's a newer thing about, penile traction, which is really exciting. There's injections, as barbaric as that sounds, those are my favorite options for erectile dysfunction. And, we're just helping them along that process. And if by some chance these aren't working and it's going over times, then there's also surgical options for erectile dysfunction, like penile prosthesis, which we'll talk about a little bit later on. But I think the main thing is giving them an opportunity to know what the potential time frame can be, and allowing them to have a decreased expectations on themselves is really, I think, liberating and freeing for the patients and their partners.
Yeah, I think that concept of grace is really important, to keep in mind in that postoperative period. And you touched a bit on surgical therapies, and so I'd love to bring Jamie Wright into the conversation at this point. Jamie, can you share with us just some of the surgical options that exist for men, should some of these other options that Kristen shared with us not be successful?
Sure. Thanks, Brian. And I guess I'd like to kind of, advance what Kristen was describing, in that the way I describe to patients or discuss with patients this process, we know that erectile function can recover, as it may take up to 2 years, sometimes up to 2.5 years if there has been a nerve sparing process. So one has to, as she described, kind of be patient. And so often we kind of hold the surgical option off for a bit. And if couples are, interested in continuing that process, or, continuing with that aspect of their lives, then the vacuum erection device or injection therapy can be very helpful in the interim. But if those things, for whatever reason, are either not successful or turn out not to be ideal for patients, there is the option, what I usually describe as kind of the top rung of the ladder. If you imagine climbing this ladder of care, the top rung is a surgical option, which is to have what's called a penile implant or a penile prosthesis. And there's really two options in that regard. And what I typically describe is kind of the most advanced, or the, kind of the Cadillac model of that process. And it's called an inflatable penile prosthesis. And that essentially, the way I think about it, is kind of a replacement part for the erectile tissue mechanism. And it is a surgical device that puts 2 cylinders surgically into the penis, and that basically substitutes for the normal erectile tissue that creates the erection. There's a small reservoir, a little bulb. It's about the size of a lemon, and that is placed inside the belly, and that holds saline, and that basically transfers fluid from that reservoir into the cylinders, which in the normal situation for the penis, the blood would flow into the penis, but this device allows saline to substitute for that process. And the way patients kind of, in essence, inflate or create the erection or return the penis to the natural state is with this small, what we refer to as the pump, and it's about the size actually of a testicle. So it's kind of pick up an extra one. There's plenty of room in the scrotum, and when one wants to have an erection, you give this little bulb a few squeezes, the cylinders fill, and it essentially mimics. It just takes over the process that otherwise is the natural erection. And the favorable aspects of that are, or when patients kind of come back and relay their experience, the things that are the very positive aspects of that are the spontaneity, the effectiveness of it. It gives what many men will describe as a more satisfactory erection than they had just prior to their surgery. And so that device, for folks who make that decision, is associated with a very high couples satisfaction rates, both for partners and patients. There's not an aspect of it that feels mechanical or foreign or that type of thing. And so we kind of put that in the algorithm, and I find that it's very uncommon that patients who ultimately make that decision are unhappy with that choice.
So I think one thing that it's important to note that the Brady is home to significant discoveries that help to preserve and restore function to men after cancer treatment. I think if we look back at the Brady's history, it's the 50th anniversary of Dr. Patrick Walsh's development of the nerve-sparing radical prostatectomy. It's the 25th anniversary of Dr. Bud Burnett's identification of the nitric oxide mechanisms in erectile tissue that paved the way for the development of oral medications like Viagra. And these are obviously very prostate-focused processes. I want to bring Nirmish into the discussion because you have a very, very broad experience treating not just prostate cancer, but a lot of non-prostate genitourinary malignancies. And what do you frequently hear after treatment of some of these non-prostate cancers?
Thanks, Dr. Matlaga, and it's a pleasure to talk today about some of these other cancer types. Pertaining to sexual function, I mostly will highlight some of the nuances related to testicular and bladder cancers in particular. Testicular cancer tends to be one that is less common compared to the other urologic cancers we tend to encounter. And there are some unique nuances related to some of the survivorship aspects of testicular cancer. As we know, testicular cancer tends to generally affect a younger population, in which concerns related to family planning, fertility, new relationships, and body image are of primary concern for a lot of these young men. And oftentimes, treatments for testicular cancer can entail things like removal of a testicle, in some cases chemotherapy, and in other cases a more extensive surgery called a retroperitoneal lymph node dissection. And the types of therapies that patients may require can sometimes have impacts on things like testosterone levels, fertility, and even ejaculatory function. And so certainly for my patients with testicular cancer, sperm banking is something that I routinely discuss with patients prior to initiation of any treatment, depending on family planning and individualized needs. And that's just simply scratching the surface for these patients in terms of these discussions. Certainly, we've talked extensively about prostate cancer. I will highlight some of the nuances pertaining to bladder cancer as well, specifically for patients who may have deeper involvement of tumors. And these are the patients that may ultimately then go on to require systemic therapies like chemotherapy, or even a more radical surgery like a radical cystectomy. And these, it's worth exploring or discussing these aspects, since these treatments themselves can have implications for sexual function. In men undergoing radical cystectomy surgery for removal of the bladder, for example, there may be similar implications on erectile function that have been discussed in the context of prostate cancer. And likewise, there are similar techniques we can employ, including sparing of the nerves at the time of surgery for selected cases that may enhance the recovery or function. One important population that we tend to sometimes not necessarily spend as much time on, but definitely warrants its own field of discussion, would be women with bladder cancer as well. In the past, it was almost routine that women who would undergo a radical cystectomy would undergo actually an anterior exenteration, or essentially removal of other reproductive organs at the time of surgery as well. And now, particularly here at Hopkins and at other leading institutions as well, we have a more push for organ-sparing approaches in women with bladder cancer in order to preserve the reproductive organs and thereby help reduce the morbidity of treatment.
So we've spent a good amount of time speaking about sexual function following treatment of genitourinary malignancy, but obviously we know, and Kristen, you alluded to this previously, there are other concerns that will arise too. And one of them is urinary incontinence, both short-term and long-term. And Kristen, I imagine this is a frequent topic of conversation with your patients, certainly at their 3-month visit post-prostatectomy. Can you share with us some of the advice you offer patients at this stage in their recovery and what timelines may look like as far as a managing expectations standpoint?
Of course. The 3-month recovery or the 3-month survivorship appointment, it really does vary amongst patients and how they're doing. And it's very gratifying for the most part to see the patient's progression when we're talking about how they were when the catheter first came out and how they are now 3 months later. Sometimes they don't realize how well they're doing until they're hearing about it. And then we're saying, you're doing pretty good at 3 months. And they're like, oh, you're right. You know what? I am doing good at 3 months. Or they might just say, you know what? I'm coughing and I have a little bit of leaking whenever I cough. But otherwise, I'm doing good. You know, they just have a little bit of leaking. And then we talk about, okay, well, how can we maximize that? How can we go ahead and kind of maximize the continence recovery? And maybe they're doing the Kegels or pelvic floor muscle exercises sparingly. Maybe they're not doing them as often as they should be doing. Maybe they need to learn how to contract that muscle and then cough, contract that muscle and then bend forward to be able to create a little bit of some tricks with that continence. Some patients have a longer time to go ahead and get the recovery process, and it can be dependent on their age. Sometimes people who are larger, who have an excess body mass, may have a little bit more time frame for that healing process. And I remind them as well, it can take up to a year before we know, what your new normal is going to be like. So you have to have that in your mind going forward, that this is going to be a progress, that this may not be overnight. For some people it is, but for some people it's not. And it's okay if you're not part of that mix. The main thing is keep the positive attitude, keep doing those exercises, trying to do pelvic floor physical therapy, who are fantastic team members. They are a specialized group of physical therapists who only deal with the pelvic floor. They deal with female and male patients with a myriad of problems. So having them connected with a good physical therapist is another fantastic idea. It also, for some patients, it just allows them more opportunity to talk to somebody. During that physical therapy session, they may talk about bladder irritants, may talk about fluid restrictions and things that may be more caustic to the bladder. So for some people, they want that. They want that extra time and that validation. And that's a great way to empower patients. Now, sometimes we talk about other things. We talk about either the pads that they're using, that depends. I mean, back in the old days, those depends they were pretty cumbersome. Now they're pretty discreet. It's amazing what the technology has been like just in the past couple of years. We might talk about, different types of obstructive devices, maybe like some types of medications that can be used to help them. Sometimes we can use a bit of a clamp around the penis to help them. And then we also talk about surgical options. And if surgical options are in the future, then we would refer them to a urologist to discuss various different surgical options for patients. So there's lots of different ways to think about the urinary recovery, and we kind of go through that one-on-one with each patient to figure out where they need to go and kind of how much coaching they need, if any, and if they need any referrals to a urologist.
Yeah, and following up on that, to bring Jamie back in for the surgical options that are available. Jamie, what are some of the ways that incontinence can be managed surgically?
So thanks, Brian. Essentially, there's really two that are in current use, or the mainstays of that. In the previous years, some patients may be familiar or have heard about the concept of injection therapy, or putting a substance in the urethra to help it close a little tighter. But those have been found to be pretty ineffective for men with incontinence, for stress incontinence. And for those, after prostate cancer therapy, primarily, who are having some trouble with leakage, there's really two options. One is called a male sling, and the other is an artificial urinary sphincter. And there's really two very different groups who are good candidates for either of those. And if we think about the spectrum of leakage after prostate cancer therapy, it can go from, as Kristen mentioned, guys who are nearly perfect. I think if you talk to men who have prostate surgery, almost all of them will say their control's not quite, 100% if they lift something really heavy or cough or sneeze. It's just the nature of how the anatomy works. But generally from guys who don't require any protection all the way to the other side, to those who have very little control whatsoever. And the good news is there's a way to get all of those guys back to a satisfactory place. And so the male sling is ideally suited for guys with a lesser severity of leakage. And we think about it as folks who are wearing maybe 1 to up to 2 pads a day type of thing, if they're physically very active. Whereas the other guys who are further along on that spectrum, they are better treated with an artificial urinary sphincter. And just in a quick overview, the sling surgery is very similar to an operation that we do for women with stress incontinence, but it is under a bit more tension than the operation that women get. And there's basically a small piece of polypropylene mesh that's looped under the urethra, very similar to if you had put a sling on your broken arm to kind of help cradle that structure. The sling is put under the urethra, and by elevating that, it helps the native sphincter muscle just do a better job. So it's kind of an augmentation of one's existing function, and it can move the dial a bit, further towards normalcy. In contrast, for those with a greater degree of incontinence, the artificial sphincter is really kind of the ideal replacement part. It is a mechanical mimic of the normal muscle that's wrapped around the urethra. And if that is weakened by the therapy process, this device can be placed. There's a little ring that's put around the urethra that can be, when inflated, it compresses the urethra, and it works almost identically to the normal muscle, except that it's a mechanical device. And similar to the penile implant that we spoke of, there's a small reservoir, good bit smaller. It's about the size of a golf ball when inflated. And the saline that's in that balloon is used to pressurize this cuff, this ring around the urethra. And the only thing required of a man who has this device in them is there's a small, additional small piece. We again refer to this as the pump. It's about the size and shape of your thumb. And if you squeeze that little bulb on the bottom of that, it basically opens the cuff. So the device is on 24/7, holding back the urine, restoring continence until one wants to urinate. The only thing that's required is about 2 squeezes of this bulb, normal urination, and the device then automatically cycles itself. So both of those surgical processes are pretty easy. They take about 60 to 90 minutes, can be done as an outpatient procedure, and the recovery is pretty speedy. And those 2 devices can, in almost all cases, get folks as close to normal as possible. So terrific solutions if one should need them.
And Nirmish, you touched a bit on bladder cancer previously, and I think it would be hard to imagine bladder cancer treatments not affecting bladder function and continence and control in some way. Can you share with us a little bit about how you work with your patients navigating bladder cancer and how some of the therapies will ultimately affect their voiding function, really?
Absolutely. So in the context of patients who may require a radical removal of the actual bladder itself, the radical cystectomy, the challenge then is to essentially determine what the optimal approach for a urinary diversion would be. So how can we get the urine out of the body now that the bladder is out? And so there are multiple ways of performing these diversions. These include generally 3 flavors, one being an ileal conduit, which essentially is a stoma or an ostomy that goes to the skin. And these are generally incontinent routes of excretion where there's a bag that's externalized and that collects the urine. There's also something called an orthotopic neobladder, where essentially bowel is refashioned into connected to the ureters on one side and the urethra on the other. It's completely internalized, and the idea is that it would allow for patients to be continent and void in a normal fashion. And then the third option is something called a continent cutaneous diversion, or essentially a continent pouch that's created, and there's the ability to essentially excrete the urine by placing a catheter through the stoma anytime that voiding is necessary. There are a number of selection factors that may make a patient eligible or ineligible for a particular type of diversion, but as a patient, the most important thing is to be aware of these options and to ensure that you have a discussion with your surgeon regarding these options, and having a shared determination as to which may be the right option for you in this setting.
Thanks, Nirmish. And moving now from we've focused on sexual function, now voiding function. There's another condition that one can see, both related to cancer therapies as well as non-cancer therapies, and its treatment falls in a category of urology called reconstructive urology, which Dr. Wright, Jamie, is one of the world's authorities in. And something that you see in your practice with some frequency is a urethral stricture. Can you share with us what a stricture is, what symptoms are associated with it, what causes them, what treatment, essentially stricture 101 in a few minutes, if you could.
Sure, Brian. Thanks. So in this easiest way to think about the stricture is just a narrowing of the tube, the urethral tube that we urinate through. And essentially it's secondary to any process that would cause a scar to form, and basically kind of narrow down the caliber of that tube. And the primary symptom of that is difficulty voiding. The bladder has to generate a lot of pressure to try and push the urine through this kind of choke point. And it can lead to infection, and in certain situations, potentially injury to the kidneys. But mostly from a quality of life standpoint, it's just a difficult problem to tackle. And the mainstays of treatment for that are basically a procedure that can be done through the penis from the inside, what we refer to as an endoscopic procedure, which essentially either cuts the stricture, cuts into the scar to widen it, or dilates or stretches that. Those procedures we know have a high failure rate. They can be done repetitively, but the ongoing success begins to go down. And this is in contrast to a more complex procedure, a reconstructive procedure that's done primarily with curative intent. The challenge with that is that it's not done by many urologists. It requires a specific skill set, and it's a kind of a complicated process for patients to go through. It often involves grafting. We have to add a new piece to the urethra, and often the tissue segment that we use for that is a piece of the inside of your cheek. It's uniquely suited to that. It's used to being in a wet environment. It's pliable, and it lends itself. It's very similar to the lining of the urethra. And so those two things, based on the nature of the stricture, conversations with patients are pretty much the mainstay of surgical intervention.
And I think all of us would recognize that there's really great unmet needs in the treatment of patients with urethral strictures. And you're working to address one of them as you're developing a novel device and surgical approach to help treat men with urethral strictures. Can you share with us a little bit about this project and progress and what the ultimate aim is of it?
Yeah, I'd be glad to. Thanks. So, and incidentally, I would say so my lab, our group is working on, as I mentioned before, kind of bridging this gap between in treating urethral stricture disease. That we know that the endoscopic procedure is easy to do, and it's effective in that it's minimally invasive, but it's also minimally effective. Over time, there's a high recurrence rate. And we know that the surgery, the open surgery, is complex to do. So it's difficult, but it is effective. And so we're basically working on a device and a technique that would allow us to do the open surgical procedure from the inside. So it's essentially an endoscopic urethroplasty, and it takes that graft material from the cheek, and through a procedure that we can do that's similar to a cystoscopy, cut the stricture. So we borrow that part of it, but then it plants the graft this device from the inside of the urethra. And that project, incidentally, we were able to secure some funding from the university, but also it really got off the ground through help from our philanthropic efforts and the participation and collaboration with patients and friends of the Brady. So we're all in this together. And we recently, our group and the university received a patent for the device, and I would think, if I had to estimate, hopefully a little bit more than halfway through its development. We have a bit more to go, but if we're on schedule, we're hoping in about a year or two to be able to do a kind of the first in human trials of that device. We have the prototype, and we've done some work in an animal model, and so far it's been successful. And we hope that, again, through all of our participation and collaboration, that we'll be able to take that to the finish line.
Yeah, and moving the focus a little bit now to upper tract urothelial cancer. Nirmish, you, along with Dr. Hoffman-Sensitz at the Cancer Center, direct the multidisciplinary clinic for patients with upper tract urothelial cancers, and have a practice filled with patients facing a bladder cancer diagnosis. Treatment for this can involve sometimes bladder reconstruction or bladder repair. What are some of the common concerns that patients express, and how do you and the care teams respond to them?
So navigating a new diagnosis can be both challenging and daunting for patients at the same time. And I will just mention, thanks to the Greenberg Bladder Cancer Institute, we've really brought together a very talented team of multidisciplinary experts and resources that have really been helpful, I think, for patients, and have really advanced many of our research efforts and clinical trial offerings. We often very closely in multidisciplinary teams between ourselves as urologists and our medical oncology colleagues as well. And you alluded to the upper tract urothelial cancer multidisciplinary clinic. There now also is a new non-muscle invasive bladder cancer multidisciplinary clinic. And these have been, I think, in our experience, particularly helpful for patients, and specifically having our talented navigators quarterback these multidisciplinary clinics have been helpful for patients to understand their diagnosis and understand treatment recommendations that we have to offer, and help really guide them through their journey for cancer treatment, especially for complex cases that are sometimes better handled at a tertiary referral center. And so having the ability to offer clinical trials and other aspects of treatment that may not be readily available elsewhere, I think are aspects that efforts like our multidisciplinary clinics and like our Greenberg Bladder Cancer Institute have been able to offer to patients.
So I think turning the focus a bit to kidney cancer, what for kidney cancer patients, Nirmish, what are some of the common questions and concerns that you see from them? And also bringing into that conversation the idea of surveillance strategies, the disarm registry that you lead.
Just like with other cancer types, kidney cancer is also very much a spectrum, and having a team-based approach is sometimes very paramount to care. Specific to questions that I get in my practice, being a surgical practice, these are patients who may have been found to have a kidney mass, and we're trying to determine, what type of surgery is necessary, how is the surgery done, will I have full kidney removed or just a part of the kidney, and how does that affect my lifestyle? Is it possible to live with one kidney? Will I need dialysis? And these are all very good questions. Each patient's approach is undertaken in an individualized fashion. Whenever possible and feasible and appropriate to do so, without compromising cancer care, we try to make every effort to simply just remove the tumor and not the kidney itself. And oftentimes try to do this using state-of-the-art robotic approaches that are minimally invasive and often hasten the recovery for patients. But there are certainly scenarios where, from a cancer perspective, having to remove the whole kidney is necessary in order to not compromise the cancer care. The good news is that we have two kidneys, and oftentimes in the absence of any obvious compromise of the other kidney, even removing one kidney may not even impact a patient's quality of life at all. In fact, normal healthy patients that are live donors for patients needing transplants can often live their normal lifestyle without having to make any significant changes in their diet or other factors. At the same time, if necessary, we also have the ability to make referrals to our nephrology colleagues, and that way kidney function can be closely monitored if there's any concern for any renal compromise after treatment. Now, with respect to the surveillance strategies and the disarm registry, it is a unique offering at Hopkins. And just to give a bit of background, historically, whenever patients would walk into the room and be found to have a new diagnosis of a kidney tumor, standard approach would be to simply sign this patient up for surgery, and that would be the end of it. However, nearly now 14 years ago, the disarm registry, or the delayed intervention and surveillance for small renal mass registry, was created at the Brady, and now also has 3 other participating sites. And this was designed to help understand what the natural history of small kidney masses, defined as those renal tumors less than 4 centimeters in size. And what we've learned over time is that many of these actually tend to be not aggressive, and as a result, active surveillance is very much a safe and appropriate strategy to offer to patients. And the last sort of thing I'll mention is we also have had a number of breakthroughs from our research side that has now been implemented clinically. For example, with non-imaging techniques such as a sestamibi PET scan, and the completion of a recent multi-institutional trial looking at an imaging agent called girentuximab, which have been elemental in trying to differentiate benign and malignant renal tumors and help guide treatment for these patients. And we have a number of other ongoing efforts to help identify candidate biomarkers, among other imaging techniques that may help in the future for stratifying care for patients with kidney tumors.
Thanks, Nirmish. That's an incredibly thorough overview of kidney cancer and how it can affect survivorship in so many ways. What we'll do now is we'll transition to the question answer portion of our time today. And what I'll do is I have the questions are coming in fast and furious. So we're going to try to go through as many as we possibly can through them. And as some of them have come in, we've tried to sprinkle the answers to them also in some of the discussion points we've had already. So what I'll try to do is triage them to whoever's wheelhouse seems to make the most sense. But then if it's not one of you, please the others. If you want to contribute, please jump in also. I think the first question is with kidney cancer, or really any of these genitourinary malignancies, and this will be for Nirmish, are there special diets or nutritional regimens or anything like that you counsel your patients on?
So in general, I largely encourage just a healthy lifestyle, a healthy diet, maintaining normal physical activity. And this way, one can really keep their immune system at its peak function. What we've learned in recent years is that the immune system plays a paramount role in terms of trying to combat cancer in general, and this does apply to genitourinary cancers as well. Oftentimes, there isn't a need for a special diet per se, for just by virtue of a cancer type. But in some instances, particularly in cases where, for example, kidney function is severely compromised, there may be some benefit to altering the diet, and oftentimes that can be done in collaboration with one of our nephrology colleagues to help identify the best diet for a particular case.
And do you give credence? There is the concept of cancer prevention diets. Is there anything to that, or is it more just kind of the normal healthy diet that our mother and father told us to when we were little?
There have been efforts to try and explore whether, for example, that there have been questions of do high glucose or high sugar diets potentially cause harm, for example, or what is the role of for example, obesity and its relationship with cancer types. And there are loose associations that have been seen, particularly for the obesity aspect of things. We do try to largely, though, support the role for maintaining a diet that would, in general, try to keep your body at its peak health and fitness level, more so than necessarily a specific prescribed diet for like a cancer prevention strategy.
Thanks. And this one for Kristen. I'll build off the question because the question has a very specific, if, at a certain time point, you're still experiencing symptoms post-prostatectomy, when do you escalate for further care? But I guess what I would ask is what is that timeline that you counsel patients on? Is it when you get to 6 months and there still is incontinence? It's merits a referral to someone like Jamie for consideration of surgical options, or is it 12 months? And are there fixed cut points, or is it really tailored? All patients, all people are different and have different biases and tolerances and those sorts of things. And how do you have a formula of how you move patients through that continuum?
That's a good question. I think a lot of it does depend on the patient and their goals. Many patients have, they don't have a lot of bother. They may say, hey, listen, I'm going through 2 pads a day, and it's fine. I'm living with it. I'm alive. I'm healthy. I'm able to see my grandkids. It's not a problem with me whatsoever. And there are other patients who might be going through 2 pads a day, and it's really, really bothering them. And I try never to discredit that patient. I might say, if we're looking at a continuum, if we're looking at, patients at a continuum on the grand scheme of things, you're doing pretty well. But I'm not living your life. I'm not in your shoes. And if this is a bother to you, it's a bother to you. And we need to take a look into that further. I usually try to remind them that it can take time. If they're having urinary issues, I try to tell them about a year. Now, if they're really having some difficulties with incontinence, at 9 months, I may say, okay, let's have you go see one of our urologists. Let's see what they say. They may say, you're not a candidate yet. Let's go ahead and kind of see how things are going. But at least you'll have the consultation. At least you'll have kind of your foot in the door. But I usually give them about, a year time frame when it comes from urinary perspectives. But it also depends on the patient and their bother with it. I think that's very, very important to remember. I have a patient who wants to go, wants to go to the Holy Land. He's got booking a tour in September. And he's like, I really want to be a little bit drier than I am now. And that's an important goal for him. I'm like, okay, well, how can we get you there? If this is important to you, it's important to us. And then we might have to get him in a little bit quicker than I would go, or I'd recommend for somebody else. So this may not answer your question in entirety, but it's really saying that it isn't individual based. It's based on the bother, and it's based on what the progression is. If I'm seeing them and they're like, gradually decreasing the pad count, I may say, we're getting there. Keep up the good work. We're getting there. If I see we're a little bit stagnant, then we might want to try to escalate that and have them go to a urologist. So hopefully that answered the participant's question. Okay.
Brian, I'd add one thing to what Kristen is saying, and that is, if the symptoms are really severe, I think there's no harm in waiting. And what I tell patients is generally the window of opportunity to do a corrective surgery, if that's necessary, is never going to close. And so some patients can tolerate those symptoms, and they're, hopeful, and they want to do the very best they can to see if recovery will reach some maximum, and that's fine. So they're not going to miss an opportunity for that. But on the other hand, if things are very severe, and as Kristen has pointed out, if there's a lot of bother there, then I encourage patients not to wait. If there's, if you're almost back to normal, then, take as much time as one is comfortable giving themselves. But if things are really severe, and it looks like for whatever reason you're in that group that is going to require something, then there is also not a reason to wait. So I think that it's again, very individualized, but 2 things are important. If the bother is very high and we just want it to be fixed, let's get after it. On the other hand, the window remains open until such time as you want to, address that condition.
Yeah, thanks, Jamie. And Jamie, I'll keep you on for the this question. And there's a couple of questions that have come through with a similar theme, and it's really that horizon scan of what's kind of the new latest and greatest in therapies for sexual dysfunction after prostate cancer surgery or incontinence. And these are things like shockwave therapy, low dose shockwave therapy, or stem cell treatments. So what do you see as, have there been any new things in the past year or two that are really either paradigm shifting or practice changing? And then what do you see on the horizon as things we may be hearing about in 1 year, 2 years, 5 years?
Yeah, so I guess the disappointing thing is I would say that there's not really anything new that's quote ready for prime time. I think the shockwave therapy still is a very, at least from our perspective, kind of a experimental concept. There's lots of enthusiasm about it. You'll read a lot about it, but it's not FDA approved. And I think that the data, there's not a lot of great data to suggest that that's a very viable option. The holy grail in both of these areas really that we, hold hope for really is in the area of kind of regenerative medicine and tissue engineering and that type of thing. And unfortunately, the time horizon for that is probably more in the 10 to 15 year range. We're always, folks are working on medications to try and, target sphincter tone. The medicine that we use now called imipramine that can be helpful in mild cases is, 30 years old or greater. So those are the things that may be around the corner, some medication concepts, but the solutions that we have now really do have a time-tested legacy. As I said, lots of great work being done, but nothing that I think is gonna be on the horizon in the next 1 to 2 years.
And also, Brian, just to piggyback on that a little bit, many patients are really encouraged and they're really, really excited about shockwave therapy. And like Jamie said, this is still considered experimental and investigational by the Sexual Medicine Society of North America and by the American Urological Association. I think if patients go into that, we don't offer it. We don't offer it. Some urologists will offer it in private practice. Some non-urologists will offer it. So I think patients need to go into that with their eyes wide open. It's a very expensive process. It requires multiple treatments, and it is a moneymaker. I think you have to, as a patient, just do your due diligence and not just hear the commercials on TV. These commercials are there for a reason. They're preying on your vulnerability. They're preying on your insecurity. They're doing a great job. They're doing a great job with that. But we have to be mindful of what actually is working and what's not working. So I just wanted to piggyback on what Jamie said about the shockwave. There's a lot of enthusiasm, but in reality, we haven't quite seen it in action yet.
Yeah, thanks, Kristen. That's incredibly valuable insight because it is a stressful time for all patients, and you want to make sure that that there's good guidance to help support really high level of evidence care. Nirmish, what are your thoughts on new things either in the past year or two that you've found to be really shifted the way you're managing the cancer survivorship portion of your practice, or what you're excited to maybe see in the next 1 year, 2 year, 5 year horizon?
Yeah, I think we are, there's constantly new updates to our guidelines in terms of long-term survivorship. I talked a little bit about testicular cancer, for example, being an area where it's a very unique population. These are young patients, and with often decades and decades of life ahead of them. And as we get further and further along, we start to learn what is truly important to patients. And we have some exciting new biomarkers on the horizon that can help reduce the need for scans and radiation exposure. So for testis, for example, we're talking about something called microRNA 371. That'll be a blood test that may complement or even potentially supplant imaging. We also have other new imaging modalities and other candidate biomarkers that are being developed for other cancer types. One of the questions was related to, for example, the PSMA PET scan, which largely, I think, has revolutionized the way we have staged patients with cancer, prostate cancer. It is something that that I typically will employ now for patients with high-risk prostate cancers, since the evidence is unequivocal in terms of demonstrating a sensitivity advantage over conventional imaging. And oftentimes our medical oncology teams will also rely on PSMA PET scans when monitoring patients in the long run. We have a number of other active efforts in the kidney cancer space that we have been trying to explore on a research end. We have a number of different arenas in kidney cancer research, ranging from immunotherapy combinations for patients with more advanced disease to clinical trials, combining surgery with perioperative treatments. And in fact, have had some recent FDA approvals in these spaces that also have likewise changed the playing field for a lot of patients with kidney cancer. And so I think, it could deserve a talk on its own for each cancer type to answer that question. But I think we have a lot of excitement in all of these different arenas.
Thanks, Nirmish. So unfortunately, our time is starting to draw to a close. And speaking as a urologist who does not have an oncology focus to my practice, I found this incredibly informative and really just an interesting hour that we've spent together. One theme that I think came through in so much of what we discussed was great progress that has been made and is being made at the Brady, both in the past and presently, and how so much of that was really made possible through partnership with our patients, our philanthropic supporters. Whether it's Jamie kind of working to push the envelope in stricture care with novel interventions, whether Nirmish shared the Disarm registry, which is the surveillance for patients with renal masses, and that was really the first of its kind, and I think was paradigm shifting for the urologic field to begin to see how not all patients who have kidney tumors actually require the surgery and the risk and morbidity that goes into that surgery. And these things would not have happened had there not been partnership and support of our philanthropic supporters here at the Brady. And there's so much more that happens here that, again, isn't possible without that support. So today is National Doctors Day, coincidentally. And so I think one thing, as all of us who've been listening to this for the past hour, if you are captured by this concept of discovery and moving the field forward and partnering with our physicians, our staff, providers here at the Brady, our development team is always eager to have discussions about how your support can be used for that, how instrumental it is. And again, the field isn't going to move forward without it, especially much of what we've discussed. It lies in these areas of urology that maybe funding is more challenging. For example, in stricture disease, there's just not as much federally funded grants, and that makes the philanthropic support even more important. And then as I think we're less than a minute left. So just to tease for the next installment of this series is it's going to be focused on prostate cancer. And so we're incredibly blessed to be at the Brady, where Dr. Patrick Walsh really led the modern revolution in prostate cancer care 50 years ago. And Dr. Walsh will be speaking with us about hereditary prostate cancer on Thursday, June 22nd. So I would encourage you, all of you, to join with us for that presentation and discussion. And I'd like to thank you all for joining us today, and have a wonderful evening.